So guys, we're going to talk about thoracic trauma, and traditionally this has actually been the most difficult decision making that we undertake in our clinical practice. The question of who to intervene on and then which procedure we're going to perform. RSI, most of the time it's pretty straightforward. We're going to make a decision based on the patient's features, but thoracic trauma is a bit more subtle, and particularly the management of tension pneumothorax. So I'm going to talk quickly about how we recognise those patients, a little bit about the physiology because I think there are some myths around, and then focus on decision making, and then behind you there's some of the procedures that we can perform to manage particularly tension pneumothorax. So there's quite a few things that can happen to you if you have thoracic trauma: rib fractures, flailed chest, pulmonary contusions, hemothorax, which can become a tension hemothorax, pneumothorax, which can become a tension, tamponade, cardiac contusion, great vessel injuries, all nasty things. We're going to really focus now on tension pneumothorax because that's the one thing that we can make a big difference on. There's not a whole lot we can do for great vessel injuries, but when we talk about tension, these are the things that kill people and go unrecognised and undertreated. What are the signs and symptoms of pneumothorax? I want you guys to help me out. What are the signs and symptoms? Decreased saturation is excellent. That's a great first one. It's a good sign. Pain, so pain on inspiration. Agitation, yeah. Respiratory distress, agitation, excellent. High respiratory rate, excellent. Hypotension, yep, certainly that can become a feature. Hyperinflation, yeah, certainly described. Yeah, tracheal shift, certainly in textbooks. Raised JVPs there in the textbook, excellent.
And
asymmetrical breath sounds or chest movements, and excellent. So you've got a good handle on those. But actually what's important is what are the useful signs, because a lot of those are really not useful signs. So even simply auscultation of the chest and differential breath sounds, that can be caused by simply splinting of the patient's respiratory muscles due to rib fractures. It can be caused by a hemothorax. It can be caused by a tube down the right main bronchus. Things like jugular venous distension and tracheal deviation are really not seen clinically in reality. Okay, so you can sort of remove those from your thinking. But the things you guys mentioned first, which is really impressive, is the big ones: hypoxia, respiratory distress, agitation. Those are the cardinal signs and symptoms of pneumothorax that is tensioning. In many books it's described that you become hypotensive, and in some books it's actually defined as a pneumothorax with hypotension equals tension pneumothorax. And I'd like to make the argument that that is completely wrong, and that's not a good way of looking at it. There's obviously a gradation, a continuum from a patient who's got a simple pneumothorax with no positive pressure in the pleural space to someone who is literally arrested from their tension pneumothorax. And so hypotension in fact comes quite late on in the pathology. So initially what happens is, as your lung collapses due to the increasing volume in the pleural space, you get a significant VQ mismatch, ventilation perfusion mismatch, and that causes significant hypoxia way before you become hypotensive. So we want to pick our patients before they arrest from their severe tension pneumothorax, so we want to focus on those early signs. Let's talk about the physiology. There is a big difference between the spontaneously breathing patient and the patient who is being administered positive pressure ventilation in terms of the physiology. So there's a picture there of each individual circumstance. So in the spontaneously breathing patients, during inspiration, we've got 0 atmospheric pressure, 0 to represent atmospheric pressure. During inspiration, we have the diaphragm contracts. That creates a negative pressure in the intrapleural space and in the alveolar, which sucks air in. That's how we breathe. And then during expiration, as the diaphragm relaxes, positive pressure in the alveolar expels air. The difference is once you've got a pneumothorax, you can start to develop a positive pressure in the pleural space. But what's the driving pressure? What's the actual maximal positive pressure that's around its atmosphere? And really the only way you can get positive pressure is if you generate it by some other mechanism. How can we do that? How do people do that? So yeah, if we positively pressure ventilate them, we now can turn a very simple pneumothorax into tension quite quickly. How else? How is it that sometimes you see patients who are spontaneously breathing get a tension pneumothorax? So even if you have a one-way valve, you still only have a driving pressure of atmosphere. So you shouldn't really be able to get a significant positive pressure in the pleural space. But what do people do when they've got a pneumothorax sometimes? They cough and they valsalva, and that's the only way you can generate positive pressure. But it's a pretty slow process. pretty subtle, and it's extremely rare to get positive pressure in the pleural space of any significance when you're spontaneously breathing. Obviously, we see a subgroup, a spectrum bias of the most severe cases, so you will see it, but it is rare. As opposed to positive pressure ventilation. Now the driving pressure is whatever the ventilator or the bag is that we're squeezing, and we will very quickly turn those patients into tension pneumothorax if there's a significant leak. So this is where we really need to be focused, and those patients become hypotensive very quickly. So whilst in the spontaneously breathing patient, hypoxia is the dominant sign. The patient who's getting positive pressure ventilation will get hypotensive as the pleural space fills with air. Positive pressure reduces venous return and they become hypotensive. Happy with that? If we make a hole between the pleural space and the air, the atmosphere, some of that positive air will leak out, but every time the patient breathes in, what happens? Yeah, they have a sucking chest wound. That's no good. We haven't helped them at all. But in a patient who has positive pressure ventilation, if we make a hole between the pleural space and the atmosphere, the so-called simple thoracostomy, during the entire phase of respiration there's positive pressure in the pleural space and air will leak out as long as that conduit remains open. So now we can see why when we discuss the operating procedure for management of these patients, we favour making a simple thoracostomy in these positively pressure ventilated patients, as opposed to in the spontaneously breathing patient where you need a tube and a one-way system such as an underwater seal valve or a Heimlich valve. And so then it becomes a question, when we're managing our patients, how are we going to manage that? And we have a few options, so I'll get you to come and look at this. So very simply, there are three ways of dealing with the tension pneumothorax. Needle thoracostomy. Okay, we've probably all seen it done, some of us will have done it. Tube thoracostomy, which is the sort of standard that you would do in a hospital, emergency department or operating theatre when someone has a pneumothorax or tension pneumothorax. And then we have the so-called simple thoracostomy. Simple thoracostomy is simply the procedure of the tube thoracostomy without the tube. Everyone happy with that? We're going to make a hole through the chest wall into the pleural space, and we're not going to put a tube in. We're not necessarily going to do any sort of other procedure. And in the positively pressure ventilated patient, we're going to still achieve drainage of air from the pleural space. So let's think about the advantages and disadvantages. Needle thoracostomy, any intensive care paramedic in the state can do, any intern can do it. It's a simple procedure, placing a needle, usually through the second intercostal space, mid-clavicular line, into the pleural space. It's very quick, very simple. The disadvantages are that it's a temporising measure only. Because all we're doing is removing that immediate positive pressure. Minutes later, 10 minutes later even, you've got occlusion of that conduit and then reaccumulation of air. And that's because we've got a very small cannula and they kink, they block, they migrate. In some patients, their chest walls are so big that simple cannulas don't fit through them. Now, we carry very long thoracostomy cannulas, which will reach the space in pretty much every patient, but it can become an issue if people are using simple cannulas. The other big thing is that we don't allow re-expansion of the lung, okay, because there's no removal of the air. We're simply just, gas comes out and then you get occlusion. And that means we don't fix their hypoxic problem. Now they've got a head injury and we're actually still got a hypoxic patient. We haven't dealt with the issue. It can also become a psychological crutch. We think we've sorted out their B problem, but we've not. And then we've got to deal with it again later on. So it's a temporising measure. We do use it in our service. It's particularly useful where we cannot get full access to the chest and we have to do something in a rapid fashion. And so we may delegate that to the intensive care paramedic that we're working with on scene. Can you put a needle in while we get ready to do a thoracostomy? In a patient who's a patient who's spontaneously breathing, if we just made a hole in their chest, we'd cause a sucking chest wound, so we're going to have to do some sort of procedure to enable one-way drainage of air. And that's usually done by tube thoracostomy. So we carry tubes for tube thoracostomy. The advantages are that it allows the lung to re-expand because it's draining the air, lung can re-expand, hypoxia is settled. We can drain blood. That's the big advantage for our service. So it's all well and good to make a hole and air drains out, but what happens if half their blood volume pours out? You haven't seen much of the helicopters yet, but I can tell you they are the most difficult things to clean in the world. And so if half their blood volume pours out, we would convert the simple thoracostomy to a tube thoracostomy. The disadvantages are that it takes quite a while to do. You watch them done in emergency departments, and then sometimes they're still doing it 20, 30 minutes later, stitching it in and doing fancy things. But it's still slow because the patient's alert, awake, and that means that you've got to sedate them, you've got to analgese them, or use topical anaesthetic. There's a big risk of blockage and kinking of any closed system, particularly an issue for us when we fly at altitude and we can't easily reassess the closed system. We don't ever want that to happen, to occlude and then the patient to arrest. Happy with that? And there's an infection risk because we're not going to be doing it as cleanly as you will in an operating theatre. As much as we might splash some betadine on, have sterile gloves, it's intrinsically a dirty procedure, and now we're sticking a big foreign body in the wound. Most patients who need a tube thoracostomy have other injuries, and we would generally prefer to convert them to positive pressure ventilation by intubating them, because they're generally going to have other injuries and those need to be managed. And then we can achieve the simple thoracostomy in a very rapid fashion once they're completely anaesthetised and asleep. So the big advantage of simple thoracostomy is that you can do it very quickly. 30 seconds is all that's required to do a procedure. Simple tools. It allows the lung to re-expand. It's very easy to troubleshoot. So as you're going on through the resuscitation, patient becomes hypotensive or hypoxic again and you're not sure what's going on, you simply put your finger in. You feel the lungs expanded. Good, that's not the cause. There's a reduced infection risk. Studies show that the infection risk is equivalent to an in-hospital tube thoracostomy. So we can be assured that we're not making these patients all die of sepsis after we've saved their lives. But clearly, morbidity comes after mortality is dealt with. The disadvantages are that if lots of blood come out, it's going to be a big mess, and that could be an issue in the helicopter particularly. There are some people whose chest walls tend to close over and may need some splintage to keep them open. And those are particularly children whose ribs are very close together, and so the actual rib space becomes compressed, and so in very small children we will generally place a tube of some sort, and that can be a thoracostomy tube, a tracheal tube, cut short so that it remains an open conduit in this positively pressure ventilated patient, but prevents them from closing over. And the other big disadvantages that in the patient who's spontaneously breathing, you obviously can't do that as a single procedure. So let's have a look at the tools we've got. The needle, so we use these bad boys, okay, 12 gauge, big cannulas, goes through the pleural space and will relieve tension for a brief period of time. Will not be a definitive procedure. So if someone's had that done, they then need something else to be done. We carry a thoracostomy set, which is simply a pair of Spencer Wells forceps and a scalpel, and 99% of people, you can do that in a very quick time. If we're going to go on to do a tube thoracostomy, we've got additional equipment. We carry 3 different sizes of tubes, and we carry this drainage bag, which is a Portex drainage bag. And simply a bag, a tube, and a one-way Heimlich valve. The thing to remember about this is that it's a closed system and hard to troubleshoot, because it's not like a swinging, moving, closed underwater sealed drain. It's very hard to know that this hasn't occluded except by re-examining the patient. One tip is when you open this up, it comes with a little 30mm syringe, 50mm syringe, which you actually need to squirt air in to open this Heimlich valve to ensure that it's not sticking together. Okay, so you'll see that syringe and it will remind you, now that you've had this talk, that's what it's for. It's to squirt some air in there, open that valve and be assured that it is working and functioning as we would expect. And then we're going to either suture the tube in or we're going to tape it in depending on the circumstances. And there's some sterile gloves, some betadine and some sutures and a suture set. The other things that we have are for performing the more aggressive procedure of thoracotomy. So we have some scissors for doing that, and we've got a jiggly saw with handles for getting through big sternum. So we'll cover that much more in the actual procedure day when we're going to be doing thoracotomies on pigs. So that's going to be fun. So for us, let's think about decision making. So we've got these 3 options. We understand the physiology. We're going to make decisions. So you have a patient in front of you. Decision making is going to depend on some features of the patient, but also of the setting that you're in. And this is the art, really, of retrieval medicine, making decisions based on all of those factors, putting together the logistics as well as the patient care. So obviously we talked about spontaneous versus positive pressure ventilated patients. If someone has an isolated pneumothorax and absolutely nothing else wrong with them, you've got to make a decision about whether you're going to intervene at all. If they really are tensioning, the choices are give them some sedation and do a tube thoracostomy and take them to the hospital. If they have adequate saturations, if they have no significant respiratory distress, you may decide to watch that patient as you go. If the patient has, if you do a simple thoracostomy and lots of blood comes out, generally we're going to put a tube in and connect it to a bag. Understand that? If you can't get to the chest wall, then you're going to be doing something like a needle thoracostomy. So the entrapped patient who's you think is tensioning, you're going to do what you can. Obviously, once they come out, you're going to do something more definitive. Time and distance goes into the whether or not to intervene on these patients, because by definition, this is an invasive procedure with significant morbidity, I should say, down the line, and they get infections and other things. We wouldn't be wanting to treat patients who don't need that doing pre-hospitally. But of course, it's not so simple. We're never a 5-minute road trip from the nearest trauma centre. We are sometimes an hour, sometimes 2 hours, sometimes at night with a sick, multiply injured patient, and we don't want to have to intervene in the middle of the flight. So whether you're flying at night, whether you're going by helo, whether you're going by road, whether you're going by fixed wing, that's all going to come into it. If you fly in an aircraft, you're going to be at altitude, particularly in a helicopter where it's unpressurised, you're going to have a problem. If the patient has a small pneumothorax, it's going to get bigger, and that's going to come into your thinking. And if the patient's really sick, you're going to tube them anyway, that's fine. You're going to be making a decision based on the whole patient, not simply the one pathology. So all of those things are going to come into your thinking. So we have a way of doing, we have a procedure that we can do to determine if someone has a pneumothorax on scene. We don't have an X-ray machine, we've got something better. Ultrasound. So we will show you later on how to use ultrasound to make a diagnosis of pneumothorax. The big challenge for you though is to apply that knowledge to the patient, because all ultrasound will tell you is whether or not the patient has a pneumothorax. It will tell you nothing about the size and whether or not you should intervene. It's been described as 101% sensitive, and that it is too sensitive, and it picks up very small pneumothoraces that don't need treatment. So this is the challenge for you guys, and we'll talk you through how you might use it. So we've talked about the major injuries and focusing on pneumothorax, talked about physiology, the techniques and procedures, and the decision making. Any questions after all that?